Hi, my name is Dr. Debbie Lyons. I'm excited to be here today with you for Hospice Care of the Low Country. We've been putting together some vignettes and programming so that you all can listen and see and learn all about not just Hospice Care of the Low Country, but some adjunct services that are available. I'm thrilled today to talk to, I shouldn't say old friends, but sort of like old friends. We're here with Mike Falvo. He is the owner of Griswold Home Care. Mike, hi.
Hello, everybody.
Karen Lindstrom, Home
Good
Health.
morning, Debbie. Good morning, Mike.
How are
Good
you? And
morning.
you're with Kindred at Home.
I am.
I am excited to talk to both of you today because, quite frankly, in preparing for this discussion, I've learned enough to be dangerous. So I'm really excited to talk to both of you. First of all, I'm going to ask each of you individually. Mike, can you share a little bit, if you will, about Griswold and exactly what it is, and then a bit about how it differs with home health care? And then Karen will go to you after that to share, Karen, I'm sorry, a little bit to share a bit about what you do. So Mike, let's start with you.
Okay. Thank you, Debbie. And Karen, it's good to see you also.
Good
Appreciate
to
the
see you
invite.
too, Mike.
You know, I think something like this is very important because I've owned Griswold Home Care for about 8 years. And one of the things that I've noticed consistently throughout the Low Country is a misunderstanding of what the differences are between home care, home health, and even hospice. And we often have folks call us and not sure what they're looking for. They're calling the wrong place. And of course, our job is always to help them and assist. But
Sure.
still, you can see that there's a need for an awareness out there. So programs like this, and to use your point, Debbie, little vignettes
Mhm.
are hopefully what will help us get to that point of where people have a better awareness and understanding. So I'm the owner of Griswold Home Care. And the reason why I'm involved in this is I stay involved in my business in the sense of I interview all the caregivers. I'm the one that meets with all the clients because I really like to try and make sure that the service are providing for these low country seniors in most cases is what they need and it meets their requirements. Griswold is the oldest national home care company in the United States, founded in 1982 up in Pennsylvania. And as I mentioned before, I've been doing this for about 8 years down here. And I have an office in Bluffton and I also have an office over in Savannah in Georgia.
So
Uh,
how do you define, Mike, home care? What does home care look like?
Home care is a non-medical service which purpose is to be able to provide assistance to whoever may need that assistance. Most specifically, we talk about seniors, but it also could be anyone who's coming off who may be in their 40s or 50s and may have hip surgery or some type of knee surgery or back surgery and may need additional service and help at home. And what I mean by service is and non-medical, and this is the big difference between home care and home health. Home care is non-medical, and home care really works with what we say is the client in providing services, better known as to help them with activities of daily living, which you may see the acronym ADLs, which means activities of daily living. And what the best way to explain that is from when you get up in the morning to when you go to bed at night, every single thing you do during the day, a person does during the day. And if you start in the morning, that may be just simply getting out of bed, going to the bathroom, showering, getting dressed, and breakfast. Those items, those tasks I just mentioned, are all considered activities of daily living. So we have clients and we provide the service. They just need help just getting out of bed, which is transferring. They need help, assistance in the bathroom or assisting showering, assisting getting dressed, or they can't stand anymore for periods of time and can't make breakfast. And this goes on and on throughout the whole day when you talk about laundry, changing linens on a bed, grocery shopping, vacuuming. These are all things that we can help provide the services for. And in some instances, we replace you doing that service. So, a sense of you can't go grocery shopping anymore, we can go grocery shopping for you. But the main point of home care is to provide assistance so that you can remain independent in your home. So if you choose not to want to go into a facility, an assisted living facility, then you want to stay at home, then home care can come in, provide the services so that you can remain independent and stay in your home and age in place.
And I love that concept. I think one of the things you taught me when I first met you, and I had both my parents with me, was it was going to allow me to be the emotional support for my mom and dad without having the additional, and I don't want to say burden, but responsibility or obligation of also doing the physical support of activities of daily living. And that resonated with me greatly. What I'd like to do, Karen, I keep saying Karen, you have to not let me do that.
That is
I
fine.
feel better than that, my friend.
That is fine, Debbie.
But what I want to do at this point is to talk a bit about what you do
Okay.
and what the medical home healthcare is and how.
Sure. And I'll kind of tag on to Mike so that it explains it a little bit with reference to how we work together as well. So for the home health side, it is under a physician's order. So we
Okay.
are the skilled care. We are under the insurance. That is our payment. So Medicare covers us at 100%, as well as many of your managed Medicare plans. Your commercial insurances, patients may have a copay, but we get into all of that with these patients. So my referrals generally will come from the hospital for somebody who's being discharged home. So Mike brought up the patients that are having a knee replacement or a hip replacement. Those are very common for us for short-term home health. Those are ones that the orthopedic generally will let us know in advance. We assist with setting up their equipment. And if it's somebody that would need additional care, we could bring Mike in and bring those so that if they can't leave the home, they can't drive. A lot of times they have driving restrictions.
So it's a very collaborative kind of thing that you all can play together.
Correct. So we try to say that they work in adjunct with us, but we also try to say we're intermittent care. So we are only there for our visits and then we are out. So we are not a long visit. Our longest visit is when we initially assess the patient. So we are just there doing the care. We are educating the patients. So they are caregivers. We are the clinicians.
Okay.
So it's covered under, like I said, it's covered under your insurance. The physician will order it. Once we get that physician's order, we reach out to the patient and we do what's called a welcome call and just let them know that the services are coming. Unfortunately, with the COVID, I don't get as much FaceTime as we have in the past where we get to meet with them. So I do a lot of phone calls. If a family wants to meet with us, I'm sure Mike can do the same. We can meet with them in a lobby somewhere. We can meet them in a park, whatever it might be, if they just do want to meet or do a virtual call, whatever it might be. But we're strictly the skilled nursing, physical therapy, occupational therapy.
Physical therapy. All right, talk to me if you will.
Sure.
Okay, so I've got 4 criteria. What does skilled look like? Just like Mike described, sort of what home healthy activities of daily living.
Okay.
Skilled.
So for instance, we have a cardiopulmonary program. Our goal is to educate the patients and the caregivers on managing their medications, managing their disease. We look at literacy levels. We want to make sure that they understand it's a white pill, they take it in the morning, but what is it related to? So somebody may know that it's a blood pressure pill, but they don't know the name and they don't know the diagnosis. So they may not know that it's hypertension is blood pressure, and they may not know that the white pill is related to the hypertension. So we are looking at the signs and symptoms, going over all of the medication and the disease involved to why that's being treated. Our goal is to keep them from going into the hospital. So we want to have them call us first. So if we have somebody like Mike in there, we want to educate the caregivers that are taking place with those patients that we see and educate them as well. So a home exercise program with our therapists, we want their caregivers to continue that, whether it be a private company that comes in or it's you, that we want to educate you for your mother and father.
Exactly. So let's kind of segue back to you
Mm-hmm.
and your caretakers.
Okay.
And so for Mike, what criteria do you use to hire your caretakers? And are there different levels of caretakers that you have for your clients? And what is the collaboration that you all do? Or how does all that work? I'm sure it's probably individualized for each patient or client. Mike, I'm
Uh,
going to take that.
it's a very good question. The state of South Carolina, in some instances, like home care is almost like a Wild West. What I mean by that is they didn't even require home care licenses until 2014.
Oh, wow.
And regarding your caregivers, they do not require any training at all for any caregivers other than some basic understanding of first aid,
Okay.
dementia, et cetera, and very basic understanding. So the bar to get into home care in the state of South Carolina is very low. The differences are between those agencies that I'm going to say are really concerned about the client's welfare, really concerned about working with partners like Kindred and having that mutual respect for what everyone's trying to accomplish is the caregivers that you're willing to work with. The
Okay.
caregivers that we work with in Bluffton in the South Carolina area, they average about 13 years experience. We don't have
Wow.
anybody, nothing wrong with age, obviously, but we don't have anyone who's 21, 22, 23. We have people who have experience, who this is their calling, and this is what they've chosen to do. And majority of them have either worked in facilities like the Hilton Head Hospital or assisted living, or they've have a CNA, which is certified nursing assistant, or a PCA, which is a personal care aide. So they have some type of certification, or if they don't have that certification, they've worked in facilities. So they have a complete understanding of the services that are needed to be able to provide the correct services to a client, whether it be dementia or, a knee replacement or back replacement. They know how to transfer. And it's very important to find an agency whose caregivers understand that, number one. Number two, to be able to collaborate and work with Kindred,
Right.
it has to do with, I would not be able to sleep at night if I sent someone in. If Karen called me and said, I have a patient that needs assistance, I could not sleep at night if I sent someone in there who had no experience.
Sure.
Because the experience is how to transfer, how to get someone up out of a chair, how to get someone up out of bed. And that's something that's very important and should not be taken for granted, along with medications, reminding them to be able to take medications. And as Karen said, and it's really not done as much as it should be, is they're trying to prevent people from being readmitted back into the hospital after surgery. And as Karen mentioned, it has to do, they're task oriented. So they're there to be able to help with the PT in the morning, a little physical activity, and then they leave. Well, we can come back in the afternoon or the next day or how many days a week and continue that, assist them with their PT based upon the guidance they receive from Kindred.
It's so exciting to me. And the more that you talk, the more questions I really have. What I hear you both say is that not only do you collaborate, but you piggyback on each other. And am I to assume, Mike, that you pretty much, what are expectations? Do you set the client with who you think is the appropriate caregiver? Is there a lot of discussion in between? And from an expectation point of view, do you match one caretaker to a client, or do you try to have a myriad of caretakers that work with that client so that it's, I guess it's just, it makes it more practical for
That's a
everyone.
very good question. And first and foremost is when we have the pleasure to work with companies like Kindred. And so Karen calls me and says, and if I may go off script a little bit, maybe we have a client who's a little high maintenance.
Right.
Well, telling me that makes me aware to be able to, the caregiver that we bring in there has, whether it be a little bit more patience, a little bit maybe more senior, a little bit better understanding,
Yeah.
or if there's someone who doesn't want to do their PT and is being resistant, then I can send you in a drill sergeant.
Got it.
Who's going to so we match up as best as possible the caregiver with the client from a personality and also from what type of needs that they require. Having said that is, we're not a matchmaker,
Right.
So if the client calls us and says, I'm not happy with this, we switch out and bring in somebody else. But we do sit down and discuss who would be best for this client. And then to your point, we always try and minimize the number of caregivers that go into a client, always. And what I mean by that is we don't like a new face coming in every day, because if Karen says to me, here's the care plan, here's what they need, and then we sit with a caregiver and we say, here's the care plan, here's what they need. Well, you're not going to do that to, if you have 5 different caregivers going in a week, you're not
Mm-hmm.
going to do it. So it's called continuity of care, having the same caregiver in, and then they get to know each other, meaning the client and the caregiver, they start developing a little bit more trust,
Okay.
because many times, a senior, and Karen knows this, they get a little concerned about PT. They get concerned about, they're a little apprehensive about it. And if you have someone you trust, you're more willing to go ahead and complete that task.
And so let me go back to you, Karen, when it comes to the folks that you send in, um, are the orders that you're given Medicare driven, the doctor's orders? And then if you in your assessment feel like the patient may need a little more PT or a little more um, OT, a little more home care, can you
Mm-hmm.
make all of those recommendations too? And I like going off script. I think this is really important that this is a user-friendly
Right.
vignette for us to talk about. This is the real world.
Absolutely. So basically what happens from the get-go, so you are aware, they do an initial assessment. We do have some protocols with some physicians for wound care patients,
Okay.
for your IV patients, for some of your orthopedic, but no two patients are the same. So we have what's called PRN visits that are tacked on to our assessments. So then the physician will permit us to add and delete services.
Got
So
it.
we can, at any given time, we can modify their plan of care. So they will have a plan of care with us that goes for a solid 60 days. And within that time frame, we're assessing and adding and deleting and doing whatever. As
Okay.
long as that patient is considered homebound, which means a taxing effort to leave the home, we
Okay.
can be in there. If that person can go directly to a doctor's office to have something done, if they are leaving the home consistently for, they can go for a meal, they can go for a hair appointment, they can do their grocery shopping. But if they are so capable of leaving the home to have the services done that we are doing in the home,
Okay.
then they may go to outpatient and have therapy at an outpatient facility. So we are really that mediator between, say, a hospitalization or a change in condition from a doctor's visit until we discharge them.
Are
So
you
what,
are you actually also looking at things like just the blood pressure and oxygen levels, and do you actually, for both of you, act as a social support? Because I know
we
it can be really
absolutely.
isolating.
And we also have social workers. So one
Okay.
thing that Mike with Griswold had said is that when they bring in a caregiver, we like to give the full picture. So we know their financial status. We'll know who their POA is.
What's that mean?
We'll know if there's a dynamic,
What's
their
it?
power of attorney. So
Okay.
we will know who we can discuss things with, initiate emails so that we can coordinate with the family that isn't there. So we, like you were saying earlier, you were talking about the dynamics of maybe a difficult patient or somebody, you kind of get a grasp of what they might react better to,
Got
things
it.
that they like and don't like. And I try to do that in an email form so that our clinicians are also conveying that information to the private services company. So Griswold would be aware and their caregivers would know, because we like to bring them in as supplemental care for
Got it.
when we're not there. So we like to look at the whole picture and everything that the patient needs. So you talk about social, we want to look at physical, we want to look at emotional, we want to look at the socialization and financial. And we try to do an entire picture and bring in all services that we can to help that patient for quality of life.
For both, what do you think are common myths about what each of you do that you would like to take a moment to dispel or discuss? And Michael, I'll kind of start with you on that one, because I think for me, um, one of my questions is, who vets the people who come in? Is there a myth that, like you said, that it's just sort of this random, you know, how does
Well,
all,
there's, there could be a laundry list of things.
okay.
Keep in mind this, that when you have a
Don't get 'em going,
when you have a
right?
caregiver,
Yeah, right.
when you have a caregiver, I can vet them, background check, et cetera, references. We always do background check references. And what that does is, their experience will give you the skill set.
Sure.
The references would give you those intangibles that, i.e., do they show up on time? Do they perform the tasks that they're supposed to? Do they sit on the couch and do nothing? That sort of thing,
Got it.
theoretically, okay? But it's still, you still can't say when you have a senior who's by themselves and a caregiver that's there, what exactly is happening in a sense of, are they doing what they're supposed to do?
Got it.
So it's an inexact science. That is why I stay involved as much as I can to be able the ones to interview, and we do those reference checks because I don't have anyone who works for me who that has not been their calling, as I mentioned before, because it's a little bit different when you go from into someone's house where it's just you and the client. You're not punching the clock. There's no
Right.
one else to watch to see that you got there on time. And as Karen knows, a lot of our clients are retirees that are down here. The family is up north somewhere else, parts of the country. And it goes to what Karen said before. We become the conduit. We, meaning home health and home care, become the conduit and the communication back to the family of
And
what's happening.
I think
And-
to interrupt and just to kind of tag on what you're saying, I think one thing that they don't realize, so many patients get attached to their caregiver and to their clinicians. They think it is going to be very intrusive and invasive on their life, and you would be so surprised. So I think from a myth standpoint, people do think that. They think this person's going to come into my home and they think it's dirty, or this person's going to come into my home and they're going to report back to my loved ones and tell them all these things or whatever. They actually get very attached when they get in there and they get out of it what really is given to them. So I think, not to interrupt you, but Mike, I think you, when you said
That's a very
the right person,
Yep.
you really kind of know when to back off, when to really relate, when to do. So you can maybe be a stricter therapist for somebody that the wife says he doesn't listen, he's stubborn. He may have a softer caregiver for someone who wants that. So you really do try to match it to what works. They do get attached.
They get attached, and when one of the services that we do offer is, if you're not happy, let us know, and we'll switch out, because it is you're paying for a service. And as Karen mentioned before, with home health, it's Medicare covered or insurance covered. Home care is only covered by private pay, which is the best way of saying it is out of your own pocket.
Got it.
Or long-term care insurance, which is very specific insurance. It's not, if you have traditional insurance, you probably don't have long care built in. And then there are some, with the Affordable Care Act, they were working on some Medicare portions, which they would cover some home care. But, it's each state can decide if they want to follow that and go with that.
Let me ask you a question, Mike. When I think I'm clear, Karen, that the doctors pretty much initiate these medical interventions. In order to start the process with Griswold and home care, can I start small and add services or time as I need it? And then for both of you, since hospice is actually hosting this for us, how does hospice play in this process? Mike, I'll go to you for these answers, and then Karen to you.
All right. What was the first question?
Oh my goodness. I know, I can't remember.
I'm having a senior moment. I'm sorry.
No, basically I was saying.
Can you add and delete? Can you start with somebody? We'll use example, Mike. Can they have 4 hours?
In other words, one of the more basic
12
fundamentals. Yes, I couldn't even remember that. Thank you.
Your shift amount, perhaps.
Yeah. Yeah, we have some standard hourly shifts, but you can start as little as 2 hours a week, once a week.
Okay.
And then you can add to that. And you can have it 7 days a week, 1 day a week. When you call us and we go through an assessment, and a lot of folks that call, and Karen can probably agree with this, hopefully, is they don't know what they want.
Oh, absolutely.
They have no idea what they want. And so they call up and say, I need some home care. All right. What are you looking for? I don't know.
I
How
don't
many
know.
days a week? I don't know. What do you need? I don't know. And so what we try and do is, over the phone, to try and identify it a little bit, as far as, can you give me a day in the life of the person that we're talking about? Can they get out of bed by themselves? Can they shower by themselves? And you kind of talk through where, so you kind of figure out during the day where they need those services. And that's why we come to, what, I need service just 2 hours in the morning from my spouse to help get up out of bed.
Exactly.
And then as the person ages further, then 2 hours can go to 4 hours, can go to 3 days a week, 7 days a week, whatever it may be. But the client drives the services.
Got it.
Meaning it's for them to decide. There are instances where, based upon, as Karen mentioned, someone having a POA, where the client may say, I don't want anyone here, but the power of attorney says, no, you have to have the service. Yes.
Safety first.
Absolutely.
Exactly. So Karen, for you, kind of integrating hospice into this discussion, because I know we've only got about 3 minutes left.
Okay.
And I want to make sure that we know how all of these play together.
Okay, absolutely. So if we have somebody and the physician or our clinicians, it's often our clinicians that start seeing a change in condition at home. So you start seeing these changes and you realize that really what treatments or what things that they are doing, they're getting admitted to the hospital more frequently. There's an exacerbation of a chronic disease. Then we would actually go and we would say, we really feel like maybe hospice would be an appropriate avenue. We reach out to the physician, we reach out to the caregivers, and then what they start doing is they start interviewing their hospices. So we initiate that communication for our patients that we see that would benefit from the service. Then once we know that it is happening, we would work, like for instance, Darlene with Hospice Care of the Lowcountry would initiate conversation with myself or with our branch and clinicians. We would know when they're going to do their assessment. We assist with providing any of the medical criteria that we have as far as what would meet criteria for them. So we provide any of our notes, any history that we might have. Then when they do their assessment and they say that the patient meets criteria, then we are going to start pulling out and doing our discharge for their admission date. So we can stop our services right upon the moment that they say they want to sign up with hospice.
So let's say that Hospice Care of the Lowcountry comes in, they've done their assessment. They can continue then with Griswold, and again, you sort of collaborate on that end of life beginning.
Right. If we are involved with a patient of kindred and working with them, and then that person unfortunately starts transitioning and they work with Hospice Care of Lowcountry, Kindred hands off to Hospice Care of Lowcountry, and it's seamless as far as Griswold can still be there and still maintain. What usually happens though is when someone is on hospice, it's more care, there's more hours per day. But because it's private pay, as I mentioned before, I always take the lead from hospice.
Got it.
Your social workers or your nurses, I let them tell the client, you need 12 hours, whatever they need, because it's self-serving for me to go in and say, this is what you think. I'm here to support, and that's it. We're here to support home health. We're here to support hospice. You're the clinicians, you're the medical, we're here to support. So what you think is necessary, based upon if it's a POA or if it's you working with the client, we're here to follow what you are looking for to be able to have the best outcome for that client.
And Debbie, everything works so closely and seamlessly. If hospice does an assessment on a patient and they don't meet criteria yet, they will call in home health and say they may not meet hospice yet, but as you see changes, would you please refer them back? And we get them back involved. So if a person no longer meets criteria for hospice or doesn't at the assessment, then we will continue that conversation with Darlene and say, you've met with this patient, they are declining again. Let's bring you back in and have that discussion and assessment again.
I'm so grateful for this time personally. When my mom and dad started living with me and we went into this, I went in, like you said, Mike, I had no idea. And I wish that people would take the opportunity to spend 30 minutes listening to the two of you, because I think you make things so clear and user friendly that you've demystified a lot of things I think can be pretty intimidating and scary. So I know personally, I'm very grateful to have the opportunity to have you both grounded in this little vignette talking about what you do. Again,
thanks for having us.
yes, thank
Thank
you.
you.
Thank you all for joining us. Have a wonderful week.